connected to this webinar, welcome. This is the webinar of MTG7, the last one of 2020. It's a pleasure of having you, all of you, with us. We have put together with Olaf and IPAG that share with me this MTG7 dedicated to sex development and maturation, a program that I think is very interesting, with touching different topics, things, projects that are ongoing within the MTG7, thanks to the effort of the people that will present you these updates. So I think that Olaf, would you like to say something as welcome? And Arlene, please go ahead.
Ladies first, please, Arlene.
So good afternoon. It's really nice to talk to you all. So my name is Arlene Smythe. I am an EPAG representative on the Endo-ERN. I'm very proud to play that part. My daughter has Turner syndrome, and I run the Turner Syndrome Support Society UK, and have been involved in Turner syndrome for 33 years. So have quite a lot of experience, and happy to share or answer questions as they come up.
Yes, and I think Luca and I should mention Manuela Brosamle, who's our second EPAG in MTG7. Most of you will probably know her, but she represents the German CAH parents, and she has been extremely helpful, as Arlene, in supporting us. And the role of the EPAGs cannot be heightened up enough, because it has been extremely friendly, but it also has been extremely precious, because your input is extremely professional in putting in the patient side into our work, daily work.
Thank you.
I see that we have 52 people that are connected, so it's good to have this, and I hope this number is, I see that it is growing, the counter is growing, so it's good. And Olaf, we start with you with the presentation. Okay. I think that, or am I correct?
Yes, you are correct. And before I share my screen with you, I would like to say that there's one change in the program today, because Anna Nordenström will not present the Endo-ERN guideline, but Cécile Brachet from the University Hospital of Brussels will connect hopefully later to present the guideline development on sex hormone replacement. The role today is to demonstrate to tell you a little bit about a project that we are starting in Germany, or have been starting since May, because in Germany the DSD topic is ranked quite important. Just today I received an email from the Ministry of Law, since the German government will provide us with a law of forbidding any genital operations in children and minors in this legislation period, which means they will have a law by mid-2021. However, this has been let's say prepared for several years. And in the preparation of the care and the structuring of DSD care, the German Ministry of Health made a call and proposal to which we responded. Maybe you can show us the next slide. Can I do that? Or no, you can do that. And this call of the German Ministry of Health was opened about 2 years ago, because they said that we need to manage the national collective care of people. So we have a guideline in Germany which responds to what we call 2K. So it's minor evidence, but a big consensus on this guideline, including patient representation. And this guideline was published in 2017. So the objective and the aim is to implement the guideline-conform management and care of people with DSD conditions. And the call included any projects that promote the care according to these guideline recommendations based on an interdisciplinary and multi-professional collaboration, meaning that we have to oh, there's Manuela. I can see you now today. She has been helpful and with this projection as a patient representative. But the objective is to provide us with centers of care for DSD in a multi-professional collaboration, because this will be needed if any procedures in children and minors with DSD are done. However, these centers should also include the transition phase, because the German government recognized that especially the care of adult people with DSD conditions is rather sparse and often not very good. So if you go to the next slide, we can see how we responded to this call, because here you can see Germany, which most of you will know, and you can see that we combined the ERN centers in Germany with some structural centers, which I'll go into, with the representatives from the patient organizations. And I will go into Frankfurt, because that's a center that provides a registry, an open source registry for rare diseases, which we will utilize. On the screen in Germany, you see on the upper half, there's Lübeck and Kiel. You can see on the right-hand side, the red dot is Berlin. You have more centers on the west, that's Essen. But the main ERN centers are both North, Berlin, Munich, and Münster in Germany. However, there are very specialized centers in Germany, like for instance Tübingen, which is in the southwest, which is a center for adults with uterine malformations, may I say so. So some centers are very specialized, or the center in Münster, which cares mainly for Klinefelter syndrome. So you not only have the problem of combining centers in Germany for DSD care, but you also have to provide or acknowledge that these centers may have a very different setting in patient cohorts, but also in professionals. We try to combine these centers and make the care that they provide transparent. And to do that, we will try to utilize the open source registry. Next slide, please. So the project aim, Projektziele is the German word. I exchanged that in my presentation, which I have, but is the development of a care model to evolve and monitor the guideline-conform management across the lifespan, so both for children and for adults, and to evaluate this care model through a benchmarking of the participating centers with a registry, and also assess the health-related quality of life of the patients in order to renew the registry or renew the center care through the registry. So we need a verification and improvement of this model. So it's a live model, which will also contain questions of reimbursement and costings of healthcare that's needed for people with DSD. Next slide, please. So what do we need? How do you create a model of care involving centers knowing that you don't have every patient seen in those centers. So how do you provide a model of care for a nation of 80 million people, which probably has several thousand of DSD patients? So first of all, we try to create standard operating procedures in how such a network will function from its inner structure, but also in relation of communication to outside institutions. So currently, the development of SOPs for interdisciplinary collaborations are created. Then we need a concept for the transition on the patient side. So how will care be provided over the lifespan? We need to touch the specialities, and the German guideline puts a strong emphasis on the psychological counseling of DSD people. So how do we involve this into the medical processes? Of course, since a law regulating surgery is looming, we need recommendations on how and what surgical interventions are needed, and if they are needed, how can they be, not to circumvent any law, but how can this law be used as a regulative mean in order to prevent unnecessary surgical interventions, because that's what is seen by the government, that some surgical interventions may not be needed. So how do we define what is needed, what is sensible, and what should be recommended for an individual? We will furthermore verify endocrine and genetic diagnostics, meaning a centralized recapitulation on how to compare endocrine values between different centers, and of course try to look at, especially next generation sequencing, genetic diagnosis to validate those procedures, also with recommendations for the reimbursement strategies. We need an operational help desk because the centers need to communicate with outside institutions, peripheral hospitals or doctors who actually will need an entry for their patients into this network. Of course, and this is what we learn currently, webinars. We need to provide training to a broad range of professionals in Germany, be it midwives, be it doctors, on what DSD is. So we will set up a range of webinars comparable to what we do on Endo-ERN. And coming to the last part, we try to include peer counseling as a regular means of care into DSD, meaning that affected people counsel affected parents and children and adults with DSD who have a new diagnosis and entry into the system. And lastly, of course, we need to implement educational tools, a defined structured education for adults with DSD who just learn about their diagnosis. Next slide, please. Okay, so currently we have defined quality indicators for centers and for measuring care, which was quite a challenge, I have to say. We are currently developing the registry, of course, based on the knowledge that we have from IDSD and EREC and all those issues that we had. But we put it on a new platform called OSSE from the German Ministry of Health. It's in the open source rare diseases registry, and make it available for us. And then hopefully in the next year, we will implement the benchmarking procedures and the quality management. And lastly, of course, include patient questionnaires for project evaluation. Next slide, please. I think here you can see the timeline. It's difficult to start any project in COVID times, but the development of quality indicators for centered care was quite a challenge. Also, of course, getting the SOPs done. In the next year, we will try to assess the registration of patients and the educational tools, and finally implement the benchmarking of the centers, which will then continue in the last year until 2023. So finally we'll come up with a model of care that can hopefully be presented to the regulatory institutions here in Germany to really implement DSD care into the healthcare system. Okay, last slide, I think. That's just, this is a huge project covering over 5 million euros with a lot of centers involved. But I was able to recruit Ulla Dönert, who did her education as a pediatric endocrinologist and diabetologist several years ago with us. And she has been extremely eager to follow this project. And please support us, because I think if we get this done at the healthcare provider model, then this could be of high interest also to the whole European community, which we present in Endo-ERN. Thank you very much. Okay, Luca, now we have 72 people listening. Do we have any questions?
Yeah, we have very just 1 minute for to ask question to Olaf. There is somebody that wants to ask something. We have a box dedicated to the question that you can use on your right side of the screen into the GoToWebinar system. If not, I may ask to Olaf, the centers that are involved in this beautiful program, German beautiful program, there are more centers than those included in the Endo-ERN, or are the same centers, and because the goals are more or less similar to those of Endo-ERN?
Yes. In Germany, we were a little bit late because the EU work, and that's why I'm so engaged in Endo-ERN, we surpassed the German government. The German government so far has no accreditation of centers for rare diseases, but they are preparing this. DSD is just one part of it, but we had some states in our federal country who already did regional accreditation of centers. So the centers in Baden-Württemberg, Tübingen, and Ulm already have an accreditation, and those we already included. Being aware that, of course, in the long range, it's similar to Endo-ERN, that any center who wants to care for a set of patients has to meet certain requirements, and it's part of the project to define those requirements and then allow through benchmarking the actual assessment if the accreditation should be kept or if this center should not care for DSD patients. So I think currently we use those people for let's say, or those centers because they're already accredited, but this may change in the future.
Okay, Olaf. Thank you very much. I think we have to pass to the next presentation. Yes, we have 75 participants now. The numbers are growing. And it's my pleasure to introduce Sasha Howard. Sasha Howard works at Queen's Mary University of London in UK, and she will talk about the genetics of delayed puberty, differential architecture of CDGP versus CHH.
Perfect. So many thanks for the invitation to speak. And the title that I was asked to speak on was the genetics of delayed puberty, the differential architecture of delayed puberty versus congenital hypogonadotrophic hypogonadism. Just trying to move this box out of the way and not succeeding very well. So the familiar presentation to all of us in pediatric endocrinology is one of an adolescent coming to the clinic with pubertal delay. And of course, one of the most difficult distinctions is whether this young person in front of you has self-limited delayed puberty or congenital hypog. And this, as we know, is a really important distinction to make, because those with congenital hypog will have long-term ongoing needs for hormonal replacement and potential infertility, whereas those with delayed puberty, which is self-limited, or as we sometimes call it, constitutional, will have, although late at pubertal entry, their normal progression through puberty, usually with normal fertility, and may or may not need any treatment with sex steroids. And it's been for quite a while now a discussion about how we might differentiate these conditions and whether genetics could be helpful in this. And we know from this fantastic but now quite old data, which has been replicated again in recent years by Barimo's group and others, that the majority of these patients, especially the males, will have self-limited delayed puberty. There will be other conditions such as hypergonadotrophic hypogonadism, although, as we know, these are much easier to distinguish because of simple biochemical tests such as raised LH and FSH. And it's really the self-limited delayed puberty versus CHH distinction that is most difficult, and really has not been, there's not yet been a good clinical or biochemical diagnostic test that's clearly differentiated these two groups. The first clue that there might be some importance of genetic overlap between these two conditions was seen with pedigrees with families with CAH, where other family members carried the same mutation, such as this stop mutation in FGFR1, but had only the phenotype of delayed puberty. And this led really to the first interest in this possibility of exploring the genetic basis of these two conditions. And when our group started this work about 6 or 7 years ago, there were about 50% of the underlying mutations in patients with CHH and Kalman's known. But the vast majority of patients with self-limited delayed puberty had no underlying known genetic condition. And we, in the era of next generation sequencing that was just blossoming then, used Leo Dunkel's Finnish cohort that had been collected with 170 families with very clearly phenotyped familial self-limited delayed puberty. And we, as I said, used next generation sequencing, and were able to, in 2016, identify the first common genetic mutations in this cohort, which was a gene called IGSF10, which was important for GnRH neuronal migration in the fetal period, but unlike hypog only presented in adolescents with delayed puberty. And we looked together with Nelly Pitalu's group in this paper to see what the overlap between our cohort with delayed puberty and theirs with Kalman's and CHH was in terms of known GnRH deficiency genes and this new gene IGSF10. And actually there were very few mutations that we found within the delayed puberty cohort that had known CAH genes. So it seemed from that there was quite a different set of mutations or mutational burden that caused self-limited delayed puberty, as opposed to that causing congenital hypog. And so we have, over the last 5 years, interrogated this cohort further with whole exome and now whole genome sequencing, and identified now 5 key genes in our cohort which cause delayed puberty, which you can see here. And then there are also some of the known HH genes that have been published in families with self-limited delayed puberty without family members with CHH. And one of the interesting things about the genes that we've identified is that they come from a mixture of different biological pathways. Some in the top left-hand corner you can see are genes that are important in the fetal period, like IGSF10 that I've mentioned, for neuronal development, migration, and therefore the development of the GnRH neuroendocrine network. Others in the top right are more classically the pubertal switch genes, and EAP1 is one of those genes that we identified as an upstream transcriptional activator of the GnRH network. And then other genes that are involved in energy metabolism, which obviously biologically makes sense from these patients that have a really pure phenotype of constitutional delay, where they are short and slim and appear to have a slower tempo of development in general, such as FTO that we identified. And then known downstream GnRH action genes such as GnRH receptor. And part of this really piques our interest because we want to understand how a gene which is involved in the development of the GnRH neuronal network might produce no apparent defects in fetal development, in mini-puberty, and only present with a phenotype of delayed puberty. And one such gene is LGR4, which appears to be important for GnRH neuroendocrine development. And in the mouse model, we see here shown in the picture that the hypermorph mice who have very little LGR4 production have down here in orange absolutely no pubertal onset, whereas the heterozygotes, which mimic our human patients, have a significant delayed puberty. And when we looked at the number of GnRH neurons in these mice, we see actually that the hypermorph mice have a significant reduction in number of GnRH neurons, whereas the heterozygotes, which, as I said, mimic our human genotypic pattern, have no significant difference. So our hypothesis is that in some way this must mean that there is an inherent functional defect in the GnRH neuroendocrine network in these individuals, and therefore at the onset of puberty there needs to be a greater push to push these patients into puberty. And this is something that we in our group are continuing to investigate in this mouse model and looking at the integrity of the neuroendocrine network in this model. But of course, we want to think about the utility of this kind of genetic discovery for clinicians, and how we can use these discoveries to help our patients. So we have, over the last 5-6 years, as I've said, gained some more understanding in our group of the genetics of self-limited delayed puberty, and there have been further advances in the understanding of the genetic basis of CAH, both IHH and Kalman syndrome. And we know that there are distinct genes in each group, but also some where the phenotype is overlapping. So we use this data to have a look at one of our recent cohorts that we've collected of UK patients who have presented with severe delayed puberty, where initially the presenting symptom was not always clear whether these were patients with self-limited delayed puberty or CHH, and to see whether a genetic diagnosis or a genetic analysis could help us to divide these patients into these two diagnostic categories. We also, of course, wanted to use this next generation sequencing data in this UK cohort to further understand the genetic basis of pubertal delay. So these, as I said, have been collected over the last 5 years under a NIHR project with a similar inclusion criteria as the Finnish cohort, with pure delayed puberty, no primary hypogonadism, and no functional cause for their delayed puberty. And what we did is we gave these patients an initial clinical diagnosis based on their clinician's assessment, but also followed these patients up to their final diagnosis so that we could see where these two diagnoses diverged. And then we did genotyping, looking for those genes that are that I demonstrated, I've shown in just pure IHH, those that are purely seen in self-limited delayed puberty patients, and those that are seen in both. And obviously just pulled out the rare predicted pathogenic variants in these genes. And from this, we were able to assign these patients a genotypic diagnosis and then compare the genotypic diagnosis with their final clinical diagnosis. These were in total 46 patients. As you would imagine, the majority are male, as we see in the clinic. And we were able to identify a clear predicted pathogenic rare variant in 7 from the self-limited delayed puberty group and 12 from the IHH group, not unexpected that there's a smaller number in the self-limited delayed puberty, because of course our understanding of this genetic basis is still more limited. And what we saw was that about 40% of these patients had a variant identified, and these were split in between the yellow, which is IGSF10, which is our self-limited delayed puberty gene we identified. The grey are the overlap, so that does make up about 50% of the variants that we identified, and the rest were clear IHH genes. The vast majority of the patients, we found only one pathogenic variant, and 10% were oligogenic. These were majority missense, but we did have 2 patients with nonsense mutations, both as you would expect in the IHH group, and some splice site and other mutation categories as shown here. And 20% of the patients were homozygous, and again, these were the patients that were in the IHH clinical diagnostic group. As we've seen from previous literature, that the patients carrying homozygous mutations in these genes are more likely to have a more severe phenotype. We did see 3 pathogenic variants in what has previously been described only in IHH in these 3 genes, and we saw these in patients who had a final clinical diagnosis of self-limited delayed puberty, but all of these 3 patients carried these variants in the heterozygous manner. So what we saw was that there was an interesting sort of split picture, that there was clearly this overlapping group where the genotypic diagnosis was inconclusive because they found a pathogenic variant in a gene that's known to cause both self-limited delayed puberty and CHH. But that in those where they had a mutation in a gene just known to cause self-limited delayed puberty, although admittedly only 1 patient, that patient had a clinical diagnosis of self-limited delayed puberty. And equally in those where they had a genotype consistent with IHH, they also had a final clinical diagnosis of IHH. So there was a good utility of genotypic diagnosis if you identify a mutation in one of the genes that are known only to cause IHH or self-limited delayed puberty. And there's a lot more work to be done to understand the genetics of this sort of overlapping group and to unpick that. So the conclusions was that there are some clear genotypic distinctions between patient groups with congenital hypoc and those with self-limited delayed puberty. But there is much more work to be done to understand this middle group with overlapping genotypic characteristics. But that we do have positive take from this study that genetic investigation may really help us to distinguish between these 2 conditions and to help to treat our patients, in a more accurate fashion, in a more timely fashion, and tailor their therapeutic management. And that really there's a lot more work to be done, as we know, in terms of understanding the genetic basis of self-limited delayed puberty, which is an ongoing task for our group and for others, and to understand this overlapping group. And that this delayed puberty cohort that we see in our clinical practice is clearly a heterogeneous group, that this kind of biological and genetic interrogation will hopefully help us to understand better. And with that, I finish. I think I'm actually a little bit early, but maybe I don't need to apologize for that. There are many, many fantastic collaborators that we've worked with over the last 6 or 7 years, which I haven't listed in full, but I thank all of those. There's our group at the William Harvey in London, UK, and obviously I thank the clinicians and the patients for their involvement and our funders. I'm happy to take any questions.
Can you hear me?
I can hear you now.
Okay. I don't see question from the audience. Can you do you have animal models of self-limited delayed puberty?
Yes, yeah. We have gene-specific models from some of our publications. So in terms of mice models, we have the LGR4 a hypermorph mouse from Maria Isabel Garcia's group in Brussels. And then we have some nice zebrafish models we have, but I think probably the mouse model is the most useful in terms of understanding the biology, because we are obviously able to generate heterozygous animals, which therefore mimic what we're seeing with our self-limited delayed puberty cohort, the vast majority of whom carry these mutations in a heterozygous pattern.
No, my question is that in humans we have evidence that low dose steroid treatment can anticipate, in some way, can promote the maturation of the axis and the activation, the spontaneous activation of the axis. Do you have evidence in your animal model of a steroid treatment that could in some way reduce or the activation of the axis, or have an impact?
No, we haven't done that, and I'm not aware of anyone that's done that. I mean, obviously these are mice where the timing of vaginal opening and first estrus is highly regulated. So in our delayed puberty type model, these are maybe a difference of 2 to 5 days in terms of vaginal opening. So it's a small window of difference. It's a significant one. What we see in the knockout mice, or the hypermorph mice rather, for LGR4 is that they have no onset of puberty at all. We haven't tried to rescue that with sex steroids, but I guess that probably wouldn't be necessarily what you're speaking about. No, I mean, I think when we talk about our patients in clinic with self-limited delayed puberty, when we can understand that this is a patient in front of us with clear self-limited delayed puberty, I think the sex steroid treatment that we are using is relatively well tolerated and effective. So our goal is not necessarily to have a better understanding of sex steroid treatment to promote the onset of puberty in patients with self-limited delayed puberty, more to understand how we differentiate this group from clearly it's very important to pick out those with CHH and Kalman's, but also there is this overlapping group, and my feeling is that there are patients in this overlapping group that may well benefit from a better understanding of what their natural history will be, because there are definitely partial HHs in that group. But I think there are probably the self-limited delayed puberty, there are some who really do have neuroendocrine defects, and it may be, and this is some work that Leo Dunkel's doing with long-term follow-up of this cohort, that if you've got an inherent defect of your neuroendocrine GnRH network, you may go into puberty, but which of those patients are more likely to have a type of hypothalamic amenorrhea phenotype, or an early menopause or andropause? So we still have a pretty limited understanding of what's actually going on in terms of the pathogenesis of these defects. I'm not sure that what we're aiming to do is better understanding of the sex steroid treatment, but more to really be able to get a granularity of understanding of what's happening with this, forgive my phrase, but lump of patients that's in front of us, and how to help them in the best way.
And do you think that in your models, the main problem is related to the number of GnRH neurons that are functioning, or there is a functional defect in the neurons?
Yeah, I mean, I think it's something that we still want to unpick a bit more, and it may be that those with different genetic mutations have a slightly different mechanism. But as I showed with the LGR4, that the HETs don't seem to have a massive difference in their number of GnRH neurons. But whether that we know from amazing work that's been done how intricate this GnRH network is. So it's not just GnRH neurons, it's all the other neuronal and tenocyte and oligodendrocytes that are interacting with these GnRH neurons, and whether, if you don't make those interactions at the right time in the correct way, whether that leaves you with some kind of slightly less functional network. And this is all quite hypothetical from our work at the moment, but it's something that we'd really like to explore more.
Thank you very much, Sasha, for your presentation, for your contribution to our webinar. And we have to pass now from London, we should go to Belgium, and in particular to Ghent, University of Ghent, and I have the pleasure to introduce Martine Koels, very well known to all of you. She will talk about the management of gender dysphoria in Europe and an update in pediatric care. She will be followed by Endo-ERN from the same institution, who will talk about the update in adult care.
So I will give a short update on the pediatric management of gender dysphoria in Europe, as long as we know this. And of course, you know all that numbers are very sharply rising, both in the USA and in Europe. Also in our center, this trend is completely followed, which even went to an explosion, and then therefore a shortage in staff, and we had to halt actually the intake for a certain time, which caused a very long waiting list and delay for youngsters to enter our clinics. Overall, around 40% of the minors who present with gender dysphoria will start with hormonal treatment, but these are mostly in the group of later presenters, because the younger children that present, in around 70 to 80% of them, the gender dysphoria will not persist, and they will not enter the endocrine clinics. These are numbers from the Tavistock Center in London, but they're probably very similar in other centers. Already in 2018, the Gender Dysphoria Working Group of ESPI surveyed around 10 centers in Europe on the organization of the medical care for transgender youth. And this survey learned us that usually the team composition is led by a pediatric endocrinologist, together with a psychiatrist, psychologist, and a number of other specialists, depending on the circumstances. The guidelines that are used in the centers are the ones by the WPATH Standards of Care and the Endocrine Society Clinical Practice Guidelines, which are mainly US-based guidelines, and we know that there are quite some differences in care between US and Europe, and of course differences in healthcare organization. Around 64% of the centers can provide GnRH analogs in all the patients for puberty suppression, also a little bit depending on the local healthcare organization. The age until which parental informed consent is necessary is a little bit different according to the center, and also the age at which gender-affirming hormones is started can differ between 15 and 17 years. Around 70% of the centers can offer continued psychological support, and in other centers this is only on demand available. In 70% there is a transition clinic, but there is no information on dedicated fertility preservation services. There is a very heterogeneous situation with regard to legal and ethical issues, and actually one can say that this is not regulated at all in a homogeneous way across Europe. Currently, there is specifically a lack of long-term outcomes of this management of transgender use, and therefore some clinicians may perhaps favor a little bit more conservative approach towards the various medical treatments. Everyone is very much convinced on the importance of registration just to help moving forward with these long-term outcomes. However, the registration has many hurdles, as we know also from other conditions and efforts, and they're actually the same hurdles with regard to the lack of staff and technical support and so on. With regard to the possible schedules that are available, the most centers use the GnRH analogs, which can be given from 10 or 2 stage onwards, so just after the start of puberty. However, in most adolescents, this will only be started at around 10 or 4, because only then the definitive diagnosis is complete. At that stage, there may be also alternatives, like in trans boys, the use of progestins, for example, in estranol, and in trans girls, the use of anti-androgens like cyproteron acetate. And I will tell you a little bit more about that. From 16 years onwards, gender-affirming hormones can be given, and psychosocial support should actually be part of the treatment continuously. Oops. There is quite a lot of literature nowadays on these treatment regimens and on the short-term outcomes of all these medications. And just to wrap them up very briefly, we can say that we know that GnRH analogs stop really the development of secondary sex characteristics, but they do not cause regression once these sex characteristics are established. They will induce amenorrhea in trans boys, and they will reduce erections and hair growth in trans girls. For linestranol, they are also able to induce amenorrhea in the trans boys, but with the low doses that we used initially, they're clearly less efficient than the GnRH analogs, with around 50% of adolescents who have from the beginning onwards already amenorrhea. With higher doses, this gets better, but there has never been a direct comparison of this effect of amenorrhea, and also on whether this has the same effects on quality of life and psychological improvement as the GnRH analogs. And for cyproteron acetate, this can also decrease the erections and hair growth in the trans girls. However, for cyproteron acetate specifically, meningioma has been reported in 6 cases with very long-term use of very high doses, which we don't actually use in these transgender adolescents, but still we need to be very careful until this is more clear. For growth, there are no conclusive data yet on the impact of GnRH analogs on final height. For body composition, we know that if you use GnRH analogs and then gender-affirming hormones, that the body composition and body shape will end up somewhere in between the typical male and the typical female reference values. In general, we can say that GnRH analogs and cyproteron acetate will result in a decrease in lean mass and an increase in fat mass, and for linestranol, it's just the opposite. There are actually no big concerns with regards to safety for the blood parameters. With GnRH analogs, we see some subclinical decrease in glucose sensitivity and a bit less favorable cholesterol profiles, but we don't know what this will give in the long term. The main concerns are probably with bone development, where DEXA scores are really clearly decreased, especially in the trans girls already prior to start. So this has probably something to do with lifestyle and not with the intervention as such. But with the use of GnRH analogs and also with cyproteron acetate to the same extent, there is a further decrease during this treatment. And then for the short-term result of testosterone in the trans boys, there is a partial catch-up, but this does not seem to happen in trans girls with estradiol. But so on the bottom, what is very clear for now and what really is difficult in interpreting the literature is that the GnRH analogs are mainly given in tenor stages 4 or 5 and for a very short time without gender-affirming hormones. Whereas when we start early, then we start already at tenor stage 2. So without any exposure to endogenous sex steroids, and for a period of 3, 4, even sometimes 5 years throughout puberty. So this may really be a completely different situation where there are very little data about. So next slide. I will give you some very recent insights from the last year. Some interesting papers have been published. This is a study from Daniel Klink's group in pediatrics, where he looked at the long-term outcome with regard to BMI and cardiovascular health in trans adults then at the age of 22. Quite a big group who received GnRH analogs, again, for a short period at 15 years and then at 17 years gender-affirming hormones. the blood pressure and the lipid profile is actually more favorable in these trans individuals as compared to controls, or at least equal. So that's very reassuring. But what was remarkable is that the mean BMI is a little bit higher than the reference values, as you can see on the right side. But for the prevalence of obesity, this is clearly higher in the trans women and in the trans men as compared to cis women and cis men, which you can see on the left side on panel B. And on panel A, you see that actually this situation is present already in the trans men before the start of GnRH analogs, but in the trans women, this is something that really occurs throughout the treatment. Then the next slide, where you see the results of a study by Sabine Hannema from the Netherlands, where she looked at bone development, and this time on a more longer term with GnRH analogs for 2 years, again for only a period of two years, started mainly in tenor 4 or 5. Some started earlier, but most of them later. And then gender affirming hormones for 3 years. So this is the first paper that offers more or less long-term use of gender affirming hormones and what the result of it is on bone development. And what we could see is that at the start, again, the trans girls have already very low Z-scores. You can see this in the left panel. And it continues to decrease both in the trans boys and in the trans girls with the use of GnRH analogs all over the treatment with GnRH analogs for 24 months. And then with addition of gender affirming hormones on the right panel, you see that there is a catch-up in the trans boys, but this catch-up occurs only partially in the trans girls, which are the two lowest curves that you see. And especially the trans girls who were started in late puberty on GnRH analogs, they do not show any catch-up of Z-scores at all. So this was a little bit surprising, I think, from this study. When you start late with GnRH analogs, when you already had testosterone exposure in the beginning, then you don't show a catch-up of the Z-scores for your bone mineral aberrant density. Then another study which was done in the US, it was a big survey of 20,500 trans individuals, young adults, and they were surveyed about their desire for puberty suppression when they were younger. And only 17% actually indicated that they would have wanted this puberty suppression. And actually only 2.5% of them really had the puberty suppression. So only of these 20,500, only 98 had the puberty suppression. But in this group who had puberty suppression, it was shown that the odds for lifetime suicidal ideation was much, much lower, and only 0.3 as compared to the ones who did not have puberty suppression. So from this study, again, it was suggested that puberty suppression in adolescence is really associated with favorable mental health outcomes. So from this study, and also in alignment with other studies, we should conclude, I think, as pediatric endocrinologists, that if gender dysphoric adolescents are really seeking this therapy, it's very important to be able to provide this treatment to them. And the next slide. However, only 3 weeks ago, the UK High Court ruled that minors below 16 years are unlikely to understand the long-term consequences of puberty blockers and to be able to give their informed consent. And this has caused the NHS England to order a pause on all the referrals of children younger than 16 for puberty blockers, and even for those over 16, the clinicians need actually, or would be wise that clinicians seek court authorization. And following this, the Tavistock Centre has currently suspended all new treatments for what I have understood until there is more clarity about this. And actually, these rules came from the study of one individual, and probably I think there were some more cases. But this individual actually was assigned female at birth, and then presented with gender dysphoria and had these gender-age analogs and gender-affirming hormones to reassign male. But as an adult, she desired to reassign female sex, and therefore she also claimed that for her it had been too difficult to understand what all the consequences of this treatment were. So of course this adds a lot to the confusion and to the drawbacks of giving this therapy in adolescence. So the next slide. And so we have to a little bit question ourselves, where are we now? If we look at GnRH analogs, they clearly have proven beneficial effects on quality of life and mental well-being of trans adolescents, and are relatively safe on the short term. But we know quite little about the long-term effects and side effects of this treatment. We know that there are some alternatives under the form of the progestins. They are clearly cheaper than GnRH analogs, but if they are as effective in late puberty and if they are equally safe or even safer, I think we really need direct comparative studies for that to be able to answer this question. What is actually very clear is that with all the overwhelming number of adolescents that are referred to our clinics, the diagnostic process probably more than ever needs to be stepwise and very careful, and really from a child developmental perspective. So we really need to understand what is happening with our adolescents before we start this treatment, and should be experienced by or done by highly experienced child psychologists. The next slide. So in conclusion, what we can say is that the chances for transgender adolescents to have treatment throughout Europe are probably highly unequal. And so we need really to map this, and there is a very timely initiative now from MTG7 Endo-ERN together with ESPI and EASY to map all these differences and to work towards harmonization in Europe, guided by evidence. And this, I think, must result in highly needed European guidelines to make more clear to pediatric endocrinologists across Europe what is really the best treatment in which situation. And to start with this, we developed a survey that is coaching the current situation in your country or region, and it will reach you in the coming months. Actually, the project has had a little bit delay because our PhD student is already absent due to illness for 6 months. But we hope to clarify the situation in a few weeks, and the first thing we will do is take up this survey, and it will come to you. So your voice is really very important in this project, and I would all ask you to complete the survey and give us the information that we need to proceed with this very important work. Thank you, and I hope you were able to follow even with the slides not going very smoothly. Sorry for that.
Yes, Martin, we were able to follow with some problems at the start, but then they were well visible to all.
Okay.
I'm that we are in a certain delay, so I would start directly with Guy presentation. We have a tight schedule, so we will postpone eventual question at the end on this topic after the talk of Guy. So now it's the turn of Guy Tzien from the University of Ghent in Belgium, who will talk about the same topic, but adult care. Please, Guy, go ahead.
Okay, good afternoon, everybody, and thanks for joining us. Martin just mentioned the case of what happened in the UK surrounding puberty blocking, and last evening and today EPAT and WPAT, the European and the World Organization, have responded to that judgment. So if you go to the EPAT website, you want to And if you want to learn our opinion about it, you may find all details there. We think it's better that child psychologists and medical doctors make those judgments rather than judges, of course. But I'm here to talk about adult care, so I'm sharing my screen. Just I'm hoping you can see everything. So my point of view as okay, thank you. My point of view as an adult endocrinologist. Well, as disclosure, I'm associate editor for the National Journal of Transgender Health and also the Journal of Sexual Medicine. I function as a president of EPAT, which is the European Professional Association for Transgender Health. So I'm going to talk about trans men and trans women. That's very obvious, but while gender is not binary, so there's also a lot of gender non-binary people, and we are just learning about them in recent years. One of the most famous examples is the singer Sam Smith, and especially for researchers, this is a challenge because gender non-binary is not one category, but it's also made up of larger variations of gender identities. So indeed, as said, the numbers are increasing enormously, almost exponentially. I started my career in the year 2000. We were already impressed with 25 or 30 patients coming to clinic. In our top year, we have seen over 500 new Belgian patients. And since then, in the red, you can see our waiting list, which is growing and growing just because there's just too many people coming for clinic. We are expanding our services, but it still will take some time. And we're not very surprised because we know the prevalence of gender dysphoria is much higher than what anyone expects. We were reluctant in 2015 to publish this data, but since then they have been confirmed. And we think in a general society about 0.5 to 1% of people do have some kind of degree of gender dysphoria. And of course, if you open your doors as an endocrinologist, you will see a lot of patients. And if you don't, you will still may have the impression that this is a rare group of patients, but it's not really the case. Scientific output has increased a lot, also over the last years. And well, looking at the possible psychiatric diagnosis, mostly anxiety and depression have been confirmed in transgender people when compared to a control population. But the good news is that with hormone treatment, a lot of this anxiety and depression gets better, even more so with hormones than with surgery. And all the other big psychiatric diagnoses are not more prevalent in transgender people compared to controls. This was also confirmed by publication from Italy, Alessandra Fischer, looking at the baseline, so without hormones, and then a follow-up of 2 years with hormone treatment, and you see the decrease in psychopathology, depressive symptoms, and body uneasiness. So my first conclusion would be that the need for transgender care is much higher than expected, and endocrinologists definitely have a role to play, not for everybody, but for those who desire a medical intervention. So let's talk about this gender-affirming treatment. Everything that I'm going to tell you has been summarized in this paper in Endocrine Reviews, the Endocrinology of Transgender Medicine, 2019. And indeed, as already mentioned, we have this Endocrine Society Clinical Practice Guidelines. Both documents are quite lengthy, so if you want to have a briefer version, focusing on the up-to-date definitions, also on assessment and hormone treatment, we published this year this position statement for ESSM, and that's maybe more easy readable for those of you who don't have a lot of time to read all those very lengthy papers. WPAT is the World Professional Association for Transgender Health, is currently updating their standards of care in the edition 8, so that will be for next year. And indeed, we have EPAT, which will have a new conference next year if all goes well. Looking at treatment, well, we have a diagnostic phase. Then usually there's a hormonal phase for those who wish medical intervention. And then it's possible to have surgery if you had surgery hormones will be continued, and it's important before the hormones that we will have a decision on gamete storage, on fertility. So looking here at the AMAP trans persons, AMAP is a novelty term, and it means assigned male at birth. So here we are looking at feminizing hormone treatment, and all the effects you probably know. They have been summarized in a paper in the Lancet Diabetes and Endocrinology. One of the most important things is to consider fertility before you start any hormone treatment, and especially in adults, it's an easier endeavor compared to younger people, of course. It's very important before we start with any feminizing hormone treatment that we are aware of the medical history of our patients. So we are especially looking out for thromboembolic disease, breast cancer, macroprolactinoma, and cardiovascular and cerebrovascular disease. So that's definitely something that's important to know. If you want to know all about the dosages of treatment, so we will use estrogens, possibly in combination with anti-androgens. We don't use the ethinyl estradiol anymore, or the equine estrogens, of course, because of a higher thromboembolic risk. And all the dosages have been described in the papers that I've just mentioned. There is a discussion in the literature on the use of progesterone in trans women because of the fact that, well, if you look at these graphs looking at breast development, we're not really doing a great job. This is a 24 months follow-up, so a lot of trans women will still stay at a stage 3. And then you find on the internet information about the fact that with progestins, trans women will feel better, that they will have a better sexual desire or better breast development. But so far, these are merely opinions, and we don't have the evidence that the use of progesterone is useful in trans women. But you find these papers by single authors, even published in the Journal of Clinical Endocrinology and Metabolism, also an opinion paper, not based on any data. And of course, then we feel the urge to write a letter to the editor saying that, well, opinion papers maybe should not have a place in such an esteemed journal. Indeed, about the sapropterin acetate discussion, so the anti-androgen meningiomas have been described, but we have to be reminded that they are extremely rare in the complete transgender world literature. 9 cases have been described. This is one of my cases where the patient, you see the meningioma here, that's increasing, and then it decreases when you stop sapropterin acetate. But it has led to the advice that sapropterin acetate can only be used for low dose of 10 milligrams for about 2 years. And if you presume that the treatment will take longer, it would be better to look for another anti-androgen treatment. And which anti-androgen is the best? Well, that's a discussion that's still out there. There are not really head-to-head studies, except for one descriptive study from the group in Israel. And you see here listed the advantages, the pros and the cons of sapropterin acetate compared to spironolactone. And well, the problem with spironolactone is that you have a less decrease in gonadotropins and testosterone, so it's less reliable towards anti-androgen monitoring. But of course, sapropterin acetate does have some side effects, so we have to advise our patients. I've seen more than 3,000 trans persons, and of those, about 2,000 trans women. I've worked with 50 milligrams of sapropterin acetate up to a couple of months ago, and I've never really had any serious problems except for this one woman who had the meningioma, which then decreased when the sapropterin acetate was stopped. Again, she didn't need to have neurosurgery. While we're on the topic of feminization, let's look at the breast cancer risk. It's increased compared to cisgender men. That's obvious, but these are relative risks. Of course, if you look at absolute risk, they're still very low numbers, and the relative risk is even lower in trans women compared to cisgender women. Also be reminded that trans men can also have a breast cancer, but chances to find one is quite limited. If you're thinking about breast screening guidelines, we just use those for just cisgender people. And while we're on the topic of cancer, prostate cancer in trans women has been described in 6 cases in the Amsterdam group, out of a group of 2,281 trans women, especially those who started at an older age with hormone treatment. So in general, we know from the especially the Amsterdam literature that the observed cancer risk does not exceed the known differences in cancer risk between cisgender men and cisgender women. Just be aware of the anatomical situation and of the hormone treatment, and then screen accordingly. Let's look at the virilizing treatment in AFAB, so that's assigned female at birth. So we're looking at testosterone treatment now. Also in this paper from the Lancet, all the different effects summarized. Here we are doing testosterone treatment based upon the principles of treatment of hypogonadism, and also here it's best to consider fertility before you start any testosterone treatment, because afterwards it becomes quite complicated. Do we need to monitor estradiol in trans men is a question which is often asked, and the answer to that is no. We know this from a study that we performed. Estradiol goes down, except for those trans men who used a contraceptive before they started testosterone. But as expected, estradiol will decrease in trans men. So, as a second conclusion, gender-affirming hormone treatment is easy, especially for endocrinologists, of course, and it's safe, but we have to look out for cardiovascular safety, especially in the trans women. I'm always reluctant to say anything without data, so I'm not commenting a lot on the gender non-binary group, because there's very few literature about that group specifically, also because it's so diverse, of course. But finding data has been the goal of my career, and we've created Energy, that's the European network for the investigation of gender incongruence, also collaboration between 4 gender teams within Europe, and we have a baseline evaluation, and then we do a follow-up until 3 years now. And we have over 2,600 included participants. We were able to realize or to generate a couple of PhDs, and briefly some data from that research. Psychology, as already announced, mostly affective and anxiety problems in trans people. That's known as for body image, well described, and also obvious body dissatisfaction is higher with regard to sex-specific body features in a group of trans people. That's obvious, but if you here look at subjective effects of hormone treatment, here both for trans men and trans women, you find some transient subjective effects and some persistent subjective effects. And it's interesting to look at this paper, because trans people can come with any complaint, and then it's sometimes difficult for us to know what is really hormone related and what is not. And here we see, for instance, that for both trans men and trans women, there is indeed a transient weight gain, but it gets better after 1 year. And hot flashes tend to stay on a longer period of time. And here we're looking at persistent subjective effects. And trans men will mention that, well, menstruation stops, and that's only a very small group that continues to have menses, and trans women will especially feel their breast tenderness in the first 3 months of treatment, and then it gets better. The pain will get better. In a lot of guidelines, it's mentioned that with testosterone treatment in trans men, you have to be careful about anger and aggression. This is just not true. It's also an expert opinion. In those guidelines, we did also investigations in a large cohort of, well, 440 and 468 trans men and trans women, with absolutely no change in anger intensity in this group over a follow-up of 3 years. Looking at sexual desire, increase in trans men, then going back to baseline and a decrease, especially in the first 3 months of hormone treatment in trans women, but you see it nicely going up again when the body is more congruent with the gender identity after hormone treatment and maybe also surgical interventions. It would take me too long to talk about all sexual dysfunctions, but also those have been described in quite a lot of detail now in recent literature from the energy study. As for medical data, well, it's a safe treatment that we offer within the study. There are no deaths, there are no serious adverse events. Treatment is looked upon as being effective and low risk. For trans men, look at erythrocytosis with the testosterone treatment, and sometimes we find a transient elevation of liver function tests, but never to a degree that we had to stop treatment. Hematocrit is a sex hormone dependent, so also here you can use the reference ranges of the hormonal sex after about 3 months of hormonal intervention, and you will see the increase of hematocrit in trans men and the decrease in trans women. As for body shape, you see the desired changes. Trans people are usually in a rush to see the effects of hormone treatment, but here it's shown with DEXA scanning. Even if you don't see the changes on a daily basis, you will see the changes happening. Of course, there's always exceptions where there's no decrease in lean body mass or no decrease in fat mass, and that would be then definitely be a reason to maybe have a look at the hormone dosages. Prolactin may go up in trans women. This has usually to do with the use of.
I apologize, but you have to close in very few seconds.
Okay, so prolactin goes up because of cyproterone acetate, and then we'll come back to normal when we stop it. So I'm going to skip some slides then. Bone health is no issue. Autoimmunity has to be looked at. There's definitely a lack of funding for this kind of research, and maybe ERN Endo may help with this, because we do have an enormous amount of data about the 2,600 participants in the study. We need to do the 10-year follow-up. The world is looking for those data. It's really timely to continue this kind of research, but as you know, transgender research is not always very popular with the funding agencies, and we may need your help. So we need a lot of people to engage in scientific research. We've only scratched the ice, even though even with this limited amount of data, big journals are interested, like Nature and the Lancet Endocrinology and Metabolism. EPOT is our organization, so you can find us on Facebook and on Twitter. And I'm going to stop here. Thank you very much.
Thank you very much, Guy and Martin. We are a little bit late. I'm sorry, but the schedule is very tight. Just one question from the audience, from Eddie Klassen. She's saying, and I want a short answer from either you or Martin. Should we consider GD still a rare condition? Because they have some discussion about this point in their institution, and if GD has to be included in expert center for rare disease and within the Endo-ERN.
Well, first of all, I think it's, sorry, Martin, go ahead.
No, go. It's fine.
Well, first of all, I don't think it's a disease. That's the first thing. But of course, it's within the medical community, so we are taking care of those people. So, but it's not really a disease. It depends very much on how your organization is. If you open the doors, if you offer care, you will see a lot of patients. If you don't, you still may consider it to be a rare condition. But it's definitely the case that these people need a lot of attention, a lot of medical care, and all the help they can need. They can get.
Okay. Thank you very much, Guy and Martin. Sorry, we have to go on with the next presentation from Copenhagen, and it's a pleasure to have Anders Juhl, who will present data on insulin-like growth, insulin-like factor 3, INSUL3, on and its possible use in DSD and delayed puberty. Please, Anders, go on. We don't hear you. Now,
can you
yes.
hear me now?
Yes.
Okay, thank you very much, and I hope you can see my slides as well as hear me. I will have a brief presentation on insulin-like factor 3, which is a peptide secreted from the steroid-producing cells in the testis, the Leydig cells, as shown here, stained against INSL-free, and these are the seminiferous tubules of an adult man. Now, INSL-free has an important role in fetal life and ensures descents of the testis. So lack of INSL-free in fetal life will result in cryptorchidism. However, in postnatal life, we don't know the role, the biological role of INSL-free. Now, this was studied by several groups, including ours, over the last 10 years. And this is a paper from a former PhD student, Katrine Bay, who actually measured INSL-free using an immunoassay developed by Richard Ivel here, and measured it in several clinical conditions, including boys with cryptorchidism. And in this paper, you can see here some of the measurements in 3 months of age, and just note here that healthy boys at 3 months of age during mini-puberty have significantly higher INSL-free concentrations compared to pre-pubertal boys later in life at 4 to 10 years of age. So INSL-free, in analogy to testosterone, increases in this infant period of hormone activity. Now, recently, because we were not able to use this immune assay anymore because we had no more antibody, and the commercially available assays did not work in our hands sufficiently. So that's why we set out to develop a mass spectrometry method by and hired Jakob, who is a very skilled senior chemist, who's now developed this assay. And here you see clear, distinct peaks of the two chains in INSL-free molecule, which give a very precise estimate of INSL-free using this method. When we compared it to the former immunoassay down here, it's called the Richard Ivel assay, you can see, and versus the mass spectrometry, you can see that there's a very good correlation, but they are not measuring exactly the same. And you can see this more here on the right in this Bland-Altman plot, that at low concentrations, it appears that the mass spectrometry measures less and higher at higher concentrations. Now, this may be due to the fact that INSL-free actually consists of several chains. The reason why it's called INSL-free is because it's insulin-like with an alpha and a beta chain connected by two disulfide bridges, and then a connecting C chain, C peptide here you can see, and the immune assay, which utilizes a antibody raised against several of these circulating forms, may actually show higher concentrations compared to what we detect with the mass spectrometry, where has been documented by our chemists that it actually, this AB heterodimer, which is what we detect in circulation, and probably that is the circulating biologically active form. Also, I can mention that this assay can detect also not only human INSL-free, but also rat and mouse, and they have different retention times, just for your information. Now, using this newly developed mass spectrometry assay, we set out to see how is it then regulated in various conditions. And first here, we constructed a reference range according to age for INSL-free throughout life until 60 years of age. And we compared it to that of testosterone, also measured by mass spectrometry. And you can see in this paper from June this month, or this year, that actually they do resemble each other quite a lot, INSL-free and total testosterone. But when it comes to diurnal variation, we looked at blood samples drawn throughout the 24 hours in healthy men. And here on the left, you see INSL-free in healthy men showing a modest diurnal variation, as opposed to the more well-known, more marked diurnal variation for total testosterone, and the two variations, average diurnal variation, are shown here. So much less diurnal variation for INSL3 compared to testosterone, even though both are Leydig cell markers. We also compared these two hormones to age. So on the left you see INSL3 in healthy men according to age, and here on the right you see testosterone according to age. And below you see INSL3 according to BMI and testosterone according to BMI. And you can see, and then finally body fat by DEXA scan. And I think the important message here is that total testosterone has a clear-cut negative association with body fat, partly driven by SHBG changes, which is well known, but this is not observed for INSL3. So importantly, I think, is that we have a Leydig cell marker which appear to be independent of body composition as opposed to that testosterone. And then we looked at HCG stimulation in healthy and in men with testicular problems. And if you look at graph number B, you can see the well-known increase in testosterone following an injection of HCG with a 53% increase in testosterone. And the colors just denote the baseline quartiles of this hormone. But in contrast to testosterone, INSL3 increased only little, on average 17%. So it's not the same, even though they are both Leydig cell markers, they respond differently to HCG stimulation. Importantly, a baseline INSL3 concentration actually correlates quite well with the HCG-induced rise in testosterone. So we think that in the future, perhaps we can consider whether or not an INSL3 constant measurement can substitute for an HCG stimulation test, but this remains to be seen. But I think this is very promising results. Now, we recently also measured this in a longitudinal series of blood samples from healthy boys. And here you see now the x-axis is years from pubertal onset, as determined by the testicular volume above 3 milliliter. So here you see the increase in testicular volume in these 10 boys according to pubertal onset. And then you see INSL3, which in some cases start to increase even prior to increase in testicular volume, but with some variation. And it looks very much like that of testosterone, even though there are some differences between those two hormones in the individual boys. It looks like here that LH secretion or LH concentration increases slightly earlier compared to the Leydig cell markers. And this is, I try to visualize here with the LH rise at which time in relation to puberty. And you can see here that the green dots shows that LH starts to increase somewhat earlier compared to pubertal onset, increase in testicular volume compared to that of testosterone and INSL3. So there's some variation. This is still unpublished, but this is a study where we looked at INSL3 in men with hypogonadotropic hypogonadism. Here on the upper left, you see those men untreated with hypo and their testosterone and their LH levels. And in the middle, you see those men who were testosterone treated with low INSL3, very low in all cases, as opposed to testosterone, which are scattered all over the normal range because they're treated with testosterone. And on the far right, you see those men with hypo who were treated with HCG, and you can see that INSL3 tends to increase somewhat towards the normal range, but clearly not as much as the rise in testosterone. So again, these two markers are both from the Leydig cells, but they are not identical, and they have a different role, we think. And finally, also here, INSL3 in untreated men with Klinefelter syndrome tend to cluster subnormal or within the low normal range. And likewise, in those treated with testosterone, they remain very low, except for a few cases. If you then look at testosterone levels, then you see, of course, in the testosterone treated men that they scatter within the normal range, a clearly distinct pattern from that of INSL-free. So there was this recent commentary in JCNM by Jorma Tobry with this smashing title. I think INSL-free emerges from the shadow of testosterone as a Leydig cell biomarker. It was accompanying our puberty study, and I think it shows promise to this new biomarker, which we offered to all MTG7 colleagues, to all of you, that if you have an interesting case where you would like to consider measuring a new Leydig cell marker to learn something more about the clinical potential of this marker, you can communicate with us and send the sample to us, and we will report back on a graph like this, where you see here the reference ranges, and then your individual patients will be shown here. Clearly, you can see that in the pre-pubertal childhood range, probably a limited value of measuring INSL-free can be demonstrated, because this is probably too low detection for even for healthy boys. This is a case with boy with cryptorganism and hyperspadias born preterm. So that's why we have also made a mini puberty study to be able to provide reference ranges in the first year of life, and this is the Copenhagen mini puberty study, where we are looking at 200 healthy infants with serial blood samples, and we are measuring them in all ways, including anogenital distance and testicular ultrasound, etc. We have blood samples and questionnaires, and this is the first paper by Margit Fischer, who's a PhD student of ours, who actually published these data. And here are some very preliminary results on the serial blood samples from this mini puberty study, where you can see the very early rise in testosterone between 1 and 2 months of age, and similarly, not with the same distinct pattern, but INSL-free activity or concentration is much higher in the first few months of life compared to that at 6 to 9 months of age. So we are currently working on providing reference ranges for INSL-free in this very early life. So to conclude, INSL-free is a peptide secreting from Leydig cells. It shows age-dependent secretion compared to that of testosterone, but much less diurnal variation, and is not associated with body fat or body composition as opposed to testosterone. We believe that a single INSL-free reflects the HCG-induced rise in testosterone, and suspect that it is a marker of Leydig cell capacity, although the clinical use of this assay remains to be seen, and I hope I'll be able to get back to you at some later point to show you what we believe it can be used for. Thank you very much for your attention. I will just show a few slides of the mini puberty boys for your joy. I have this as a poster in my office. They all participated with 5 blood samples, and I love their expressions, and this is the group in Copenhagen. So thank you very much again.
Thank you, Anders, for the very nice presentation. These data that are very important, and also for the proposal of this study for within Endo-ERN. Now I see that already the presentation of Cecile is out. Cecile is replacing Anna Nordenstrom, that was previously charged of this presentation, and she accepted to replace Anna. I thank her for this, for the availability to do this. And Cecile works in Brussels in the pediatric department of Erasmus University, I think. Okay, and go ahead, Cecile. We will. I think we will have some time for discussion for all the presentations, because I asked the organizers we can expand beyond 3 o'clock for some time. So we'll have some time. I hope that all the speakers will be available after this talk to receive questions. So Cecile, go ahead.
Yeah. Can you see my presentation?
Yes, we do.
And you can hear me. Okay, that's fine. So I'm just going to present you the guidelines that are in progress about pubertal induction and sex hormone replacement in patients with either gonadal or pituitary deficiency. So it's a teamwork, of course, with adult endocrinologists, pediatric endocrinologists, psychologists, and patient representatives, and also the precious help from Olaf and Leonie for the systematic reviews and the guideline writing. Yeah, so that's the timeline of our work. So we first had an online meeting, then a real meeting. It was the time of the real life meeting in December 2019, just before COVID. There we identified in Leiden the PCOS and also some other topics that we wanted to cover. In June this year, we had an online meeting to formulate the recommendations and to discuss the writing process. Then we had a homework, and now it's time for to edit and finalize the text. We'll probably need another, certainly need another online meeting again. So what in Leiden at the time, what were the systematic reviews we wanted to carry on? So there was the pubertal induction and maintenance in males or females with partial gonadal dysgenesis. The same question, so pubertal induction and maintenance in males or females with hypo-hypo. And then there was this question of estrogen supplementation in girls with androgen insensitivity syndrome, or what's the optimal treatment for these patients? And what is the optimal treatment for boys with androgen insensitivity syndrome, so PIES? And then additional topics were identified during our Leiden meeting. Of course, we couldn't speak of puberty in DSD and hypo-hypo without psychology aspect. The transition, because this is a guideline not only about pubertal induction but also sex hormone replacement in young adults. Of course, we had to speak about mini-puberty, aromatase, the laboratory assessment of puberty, the problem of gynecomastia, and then, of course, the general consideration that before considering puberty induction in such patients, there needs to be a good evaluation of gender identity, and a multidisciplinary team is, of course, optimal to provide support for these individual choices. So that's the work that was carried out by Leonie Wilson from Leiden, and she did this literature review, which was really difficult. And we ended up with, as you can see there in pink, very, very few studies. And except for Turner syndrome patients, we ended up with basically nearly no studies. So we had we had really identified gaps in our evidence-based knowledge. So we thought, okay, let's go ahead, although of course the level of evidence will be very low because we have no papers to base our guidelines on. So basically this work will mainly serve to identify the gaps in our evidence-based knowledge. So what's the outline of the future manuscript, I would say? So as I said, we will talk about normal puberty, mini-puberty, an overview of the DSD diagnosis and the implications of puberty during for DSD patients, the biochemical assessment of puberty, the role of hormonal therapy during puberty, and specifically the role of aromatase and aromatase inhibitors, and then the transition process. Then there is this the chapter actually on the methods and the systematic review, and then the recommendations and their rationale. So I'll go directly to the recommendations and rationale, of course. So well, the basic ones are, so for puberty induction in boys, the age to start would be 11 to 12 years of age. And we have to evaluate all boys if there is no sign of puberty before 14. In case of known DSD or hypo, we can already monitor from earlier on, so 10 years of age. We will discuss the type of testosterone preparations. We suggested follow-up every 3-6 months. If no progression, of course, treatment is suggested. There's a discussion about gynecomastia, and there's also this discussion about the late diagnosis, in which case some quicker hormonal treatment can be proposed. In girls, it's basically similar. So puberty induction is considered at 11 to 12 years. Sorry for this. And then treatment when signs of ovarian failure. So what types of estradiol? We'll discuss that. The progesterone too. The follow-up is also 3 to 6 months. And again, some special considerations when there is a height question or a late diagnosis. Now, what are the other discussions? One is about hypogonadotropic hypogonadism. So for females, we basically refer to puberty induction in girls. And in males, well, the main discussion is about the role of testosterone versus gonadotropins, and to discuss individually the chance of fertility, the availability also according to the country where the patient is being followed up. The cost and reimbursement, again, can vary according to country, and the ease of use. For the Klinefelter syndrome patients, well, they typically start pubertal development at a normal age, of course, but then, yeah, the consensus was probably to say that the patients that have low testosterone or symptoms or signs of hypogonadism need to be treated. Then the discussion is how far should we go to look for these symptoms and signs of hypogonadism in Klinefelter youngsters? What kind of monitoring should we suggest? Should we suggest a spermogram before testosterone? So all these points need to be discussed. Sorry, I can't go ahead. Yeah. And then the other specific conditions which were discussed were the PIES and KIES patients. So in partial androgen insensitivity syndrome, well, they invariably develop gynecomastia, which is a clinical problem for them, and the masculinization is a frequent complaint. So the whole question is does testosterone help, and what's the outcome really? Is it just well-being? Is it based on LH monitoring? Should we monitor hematocrit? And does giving testosterone help or accelerate actually gynecomastia? Are aromatase inhibitors an alternative? Is surgery still the best alternative? So these are the points that are discussed. And for KIES girls, so complete androgen insensitivity syndrome, of course, if gonads are in place, we do not suggest puberty induction. It's not necessary. If gonadectomy, well, puberty induction as in other females. But then there is this whole question of estrogen or androgen supplements in girls with KIES. What about the non-uterine role of progestins, which we heard a little bit about by Gitun. And again, the bone mineral density of these patients, how to interpret it, how frequently should we monitor that, and is it a useful outcome measure for the decision to add or not estrogens or androgens in these patients? So again, as I have said, you'll see that all these questions are kind of open questions, and yeah, we basically all think that this guideline will basically be a kind of a question list and a list of to-do work. So thank you for your attention and for your input.
Thank you very much, Cécile, for this talk. And I invite also Olaf to join.
Yes. I don't know if I can.
And Manuela
and seen, but here I am.
Manifest yourself.
Okay.
Hi.
Hello.
Yes. And we also should have Manuela from SEPACT in here. She was here just a while ago. I don't know if she's here with us anymore. But of course, the EPAGs are more than welcome to give their presentation or comments. Cecile, we just once did a study published 2 years ago, a clinical trial on estrogens versus androgens and complete androgen insensitivity, and found high-dose testosterone a rather safe therapy, although differentially, I think the impact is quite different. One is the maintenance of body functions, the others are things like sexual desire, etc. So how can the guideline work include, let's say, the holistic functioning of hormone replacement in such rare conditions, which is such a variety? Did you discuss that in the guideline committee? I would find that extremely difficult. We cannot hear you at the moment.
Can you hear me? Yes? Okay. Yeah, for the moment, we have subdivided. Everyone has taken care of a few chapters, of a few paragraphs, basically. So we still need to meet again, basically, nothing to discuss these aspects. The outcome aspect, actually, and in fact, outcome is not only BMD or bones, but it's also libido and quality of life. And so we'll try to at least cite all these aspects and try to give a basis for useful studies. And in fact, with patient collaboration, probably that would be the best way of having good outcome measures.
And that would be also my invitation to the EPAGs, because I think in the rare conditions we often lack structured clinical trials that give evidence for some therapy, both in CAH or Turner syndrome, which you represent. Do you think the time is ripe now for clinical trials in patients with rare endocrine conditions? Oh, we cannot hear you. You have to unmute yourself. Oh, you're still not unmuted. I cannot hear you yet. I think the audience is not ready yet to hear you.
While Arlene is trying to unmute herself, Cecile, in the work that have been done so far, the contribution of EPAGs was related mainly to what?
In Leiden, we were with Diana, but Diana is mainly for central hypogonadism.
Yeah.
And I think she insists on the way, for example, all these discussions about ease of use and having a good discussion with the patients, basically, with the cost, the ease of use and the chances of fertility, and trying to to explain really well to the patient why he would go one way or another, because in the absence of good evidence for the moment, we still have this choice, and thus the patient needs really to understand very well his condition and what would be the pros and cons of a certain choice, which of course one is easy and the other one is much more burden in terms of treatment burden. So that
we all believe that this would be an added value, no? To have the contribution of the patients saying something about these that are obviously mainly the treatment or the tools for diagnosis that and the related costs. And Arlene, can you say something?
Yeah, so I'm part of the guidelines too. Sorry about the muting. I don't know what the problem was. First of all, there's always a need for better clinical research, and I think we would all agree with that. So anything that happens, well-established support groups will welcome that and encourage members to take part. So that's the first point. I think it's really important to find out how people are responding and living with their medical hormone treatment. And unfortunately, it's often much more, are you fine? If you're fine, we'll leave you. And there isn't the time for the discussions. And I think that's where support groups and EPAGs come in, because we're probably better placed to have those more deeper conversations and feedback. So a lot of that goes on at medical conferences and also at our annual conferences, where we invite along speakers and they can talk directly to the individuals, and you probably get a better feel for how they're responding. Manuel?
Okay. I have one question that it was I received from Sabine Hennema, and is for Olaf. Olaf.
Yes.
Sabine says how challenging was the benchmarking of your project?
Well, we haven't started with the benchmarking yet, of course, but the work plan was that we first tried to define the quality indicators for benchmarking, which means that we visited or we talked with all centers and said what's important for making up the center. So we defined quality indicators, and not to go too much about it, you can find that hopefully in the manuscript which we submitted for the extra issue of endocrine, which will appear hopefully at Rare Diseases Day next year. But when you have quality indicators, what makes up quality, then of course you can define registry items which you question with every visit, or for a center. Do you have a psychologist? Do you have regular case conferences? Those are quality indicators, and of course you have to question them all the time in order to get the information back from each center. And then of course we will measure these answers and benchmark them in the way that we give feedback. You have said you will have case conferences for each case with a DSD condition, but you are having case conferences in only 70% of your patients. So where's the room for improvement? And so we try to put this from two angles. One is the center side, how's the quality of the center, and secondly, of course, the evaluation from the patient side. How do you feel that this improvement, or how does this kind of care feed back to you? What do you think about it?
I think the concern of Sabine was related to the diverse group of conditions that are included in DSD, so the numbers needed for this.
Well, we talked about this yesterday, actually, when we talked about the registry items. And of course, you will have very different approaches, maybe if you have a newborn or an adult. But in essence, the composition, for instance, for a case conference remains the same. So you have independent, you have dependent quality indicators. And that can be matched. We have a very good project which most endocrinologists may know, that's the DPV registry for diabetes patients, and it works extremely well in benchmarking the centers based on HbA1c and other measures, of course, but also how often do you go to an eye doctor, to an ophthalmologist to have your eyes checked? How often do you screen urine albumin? So just as things can be done and should be done, because it gives us a measure of the quality of care which we provide.
Okay. Is Sasha still online?
Yes, I'm still here.
Because there is a question from Dr. Somarati for you. At what stage do do you consider to start genetic test in a case of delayed puberty, and do you have any specific indication?
So I answered these in the chat box. I don't know if that's helpful. I can expand on my answers if you like, but I think that it's not standardized yet. Obviously, for patients where we would highly suspect a diagnosis of CAH, then we would go for genetic testing as soon as is possible. In the NHS, there is now a panel that's available for CAH, although it is still quite limited. For our cohort, we have an ongoing research study with funding to do genetic testing. So we have availability to do it as a research study for anyone who has either isolated delayed puberty or CAH that's panel negative, but I imagine that's not the case in every country. And it's something that we want to develop, a standardized protocol for it. But I think we're a little bit early on that journey yet, certainly for the isolated delayed puberty genetics.
There is another question related to the possible role of epigenetics.
Yeah, absolutely. That is a very pertinent question. We've just won Wellcome Trust funding to do a big project exploring a bit further into possible epigenetic and genetic basis of delayed puberty, and that's one of the arms is to do epic array methylomics on our patients. So absolutely a very interesting new area for us to look into.
Okay, I see that Anders is leaving. Have you already left, Anders? Yes, I think so. Because there was a question for Anders. If not, there is another question for Martin. Martin, are you still there?
No.
Or Guy? No. No. Okay. I don't see any other question in the chat box. So Manuela, I think that this was a very good webinar. There were contribution of all kind. We touched different topics, and it was very nice. We had a peak of participants of about 90 people, so it was very good for us. And I asked to all participants that to complete the survey that will be sent out by from the Endo-ERN Rare Endo mail, to complete the survey and send your answer to quote this that is related to the quoting of this webinar, and to give your feedback on the quality and your opinion on this. Manuela, do you want to say something to?
Yes, I'd like to say something. I think I give you a short review to 2020, the work I've done or not done. So what are my tasks? The whole task had been to publish some patient information materials on the website to Endo-ERN. But I only had the possibility in the first quarter of 2020 to publish patient information to Turner syndrome with the help from Aline and on the Endo-ERN office in Leiden, and the support from Hedi and Olaf on the Endo-ERN website. The plan was to publish all patient information from the rare diseases under MTP7, but unfortunately, I have not so much time because due to heavy workload in the office. And however, I started to collect some more patient information material to CAH in the third quarter of 2020. And I've got some more information from the UK, from Finland, from Italy, and Bulgaria. There are some still informations open, but I've got a good video from Violetta to the rare disease CRH, and the plan for 21 is at least to publish the information I have well available, and to continue to collect or request some more information so that we can publish the materials on our website and give support for the patients and maybe from the doctors. And I like to say very much for the support from the doctors, from the clinicals, from other patients, EPACs, and like to wish you Merry Christmas and a good New Year. So that's all from me. And this was a short update, and I hope it will be better in 21.
Well done, thank you.
Well done, well done. Olaf.
Yeah, I think this is fine. I'm very glad to see you all smiling and happy, and I hope that includes everybody who is participating, because it has been a rather stressful year for many. Some people have been out of work, some people have loads of work, like most physicians, but also we hear that Manuela has a lot of work. So I think it has been extremely special. So I think we've come to an end, and I'd like to thank you all for sticking with Endo-ERN. There's one sad news for 2021, and that's that the British people really have to leave Endo-ERN, but not the EPAC. That's the good news. So Arlene will stay with us, although we could talk about politics being in Scotland. Well, we will see what new that surprises 2021 will have for all of us. But I can assure you all from the coordinator's point of view that Endo-ERN is meant to stay. So we will continue this work throughout 2021 and the coming years within the European family, and we hope that the UK at some point will join us again. So Merry Christmas from Germany, and for all of you, and a happy and most important, a healthy New Year 2021. Luca, but thanks to you all. That's where it all started, in Milan, and it's too bad that we can't come to the General Assembly to Milan probably in 2021, but at some point we will see each other again. Okay?
All of you.
Yes.
And,
so
yeah, I think it was an excellent webinar. We can be happy, and Merry Christmas to everybody.
yes.
Merry
Thank
Christmas.
you very much, and thank you to
Bye.
all presenters. Bye-bye. Stay
Thank you.
safe.
Bye.
Bye-bye.
Bye.